So we will have some audience questions also, so that so what's the situation in Hyderabad of COVID, sir? Is it increasing or now increasing or going down?
Everybody who has cold and fever, they stay at home, they don't get tested.
No, they're doing a home test now. Everybody's doing a home test.
sir,
And when they test it is positive, then they don't do any further tests. If it is negative, then they go for the lab test.
Acha. Okay.
I think everybody's going to get it. It's rampant.
Yeah,
Third person you talk to, and I've got fever, I'm down with fever, I'm down with fever.
Yeah. Good evening, sir. Good evening, sir. Good evening.
So how's Dr. Malhotra and your son?
Better.
Better, good.
Good evening and namaste everyone. My name is Praveer Anand. I work as General Manager with Jani Division of Intas and I am based at Ahmedabad. I extend a very warm welcome to all of you to this webinar Endocrine Talk Show, which is a very unique and interesting series of webinar. And today we are going to organize the first series of it. And that actually focuses around diabetes and thyroid. And for discussion about for that topic, we have a galaxy of endocrinologists who have joined in from various parts of the country. And I'm sure this webinar actually lives up to your expectations and goes on to serve your academic and clinical needs. So before I invite and introduce our course coordinator and anchor for today's program, it is my duty to introduce our anchor for tonight. Although Dr. Shubhankar Chaudhary sir is a very well known name, but it is my duty and customary to introduce her to all of you. So Dr. Shubhankar Chaudhary is a professor and head Department of Endocrinology, Institute of Postgraduate Medical Education and Research and SSKM Hospital, Kolkata. Sir is a former editor-in-chief, Indian Journal of Endocrinology and Metabolism. He's also
I think that should be enough. I think that should be enough.
Right, sir. And sir has to his credit more than 210 publications of various national and international journal of review. So, sir, I would like to extend a very warm invitation to you to carry on the proceedings further. Since it is a first of its kind, so you can always give a brief to the audience and take on the proceeding further. Sir. So, over to you, sir. Thank you.
Thank you very much. It's been a wonderful journey, which started right at the beginning of the lockdown era, let us say, of COVID, when we started a program called Practice Pearls in Endocrinology, which was a monthly program. Now, this is essentially a similar program in a different avatar. Now it's called Endocrine Talk Show. Now we have a wider, bigger galaxy of faculty from across the country, and some of whom have been previously in the Practice Pearls in Endocrinology. So we welcome back Dr. Bipin Sethi, Professor Sushil Gupta, Dr. Chitra Selvan, and each one of them is actually very well known. So a brief one-line introduction for all of them would be, I think, enough. So Bipin Sethi, and apart from all of them being very close to me, Dr. Bipin Sethi is an excellent person, an endocrinologist, senior endocrinologist with the Care Hospital in Hyderabad. Of course, his name and fame is not just restricted to Care Hospital in Hyderabad, across the country and beyond. We also have Professor Sushil Gupta, who is Professor of Endocrinology at the SCPGI at Lucknow. He had been with us in a previous program. And we also have Dr. Chitra Selvan, who is Associate Professor of Endocrinology at the MS Ramaya Medical College in Bangalore. So welcome back to three of you. And we have this time also very fortunate also to have Professor S.V. Madhu, who is Director Professor and Head at the Division of Endocrinology Diabetes at UCM, at University College of Medical Sciences in Delhi. He's currently, I think, editor of both the journals of RSSTI and Endocrine Society, and a very, very, of course, knowledgeable person. We also have this time Dr. Shailesh Lodha, a very senior endocrinologist once again, and he is with the Eternal Hospital in Jaipur. And the third person we need to introduce is Dr. R.N. Mehrotra. We are very happy that he could eventually join. He had some issues. I was told that he may not be able to join. So welcome Dr. Mehrotra. He is again very senior, seasoned endocrinologist of our country. So, why this topic of diabetes and thyroid disorder? Of course, we know both are common conditions, metabolic conditions that require lifelong treatment, lifelong monitoring. Whether the two occur, one occurs more often than in the general population, for example, whether you see more thyroid disorder in those with diabetes or more diabetes in those with thyroid dysfunction, may be issues that we shall discuss. We also do remember that there can be issues in picking up. For example, there may be some overlap of symptoms, for example, whether it's uncontrolled diabetes or hypothyroid or even hyperthyroid. Symptoms like weakness, tiredness, fatigue could be common. So sometimes a diagnosis may be delayed because of presence of one. Then there are issues of, let's say, comorbidities like hypertension, dyslipidemia, being seen in both diabetes and also in hypothyroid state. There are some suggestions, or it may need to be probed further, as to whether the complications of diabetes are more in those who also have thyroid dysfunction. Then there are issues of effect of thyroid hormone on glucose metabolism, effect of thyroid disorder on glycemia, effect of diabetes on thyroid dysfunction, and finally, whether there are effects of drugs that are being used to treat diabetes, whether they affect thyroid dysfunction in one way or the other. So there is a whole lot of issues to talk about, and so we have a very distinguished panel of experts to answer your queries. So all of you in the audience are encouraged to put in your questions in the chat box. Maybe we shall start off discussing amongst ourselves, but we shall, of course, pay attention to the chat box and try and address each one of your questions. So we may start off with common questions as to whether actually thyroid disorder, maybe hypothyroidism, is more common in people with type 2 diabetes. I mean, that's what most of the physicians would see. With type 1, there is clear association because of an underlying common autoimmune basis. So we won't go into type 1 diabetes, but for Dr. Bipin Sethi, a senior person like you, so whether it's, I mean, we tend to think that we see more thyroid problems in our patients with diabetes. Is it just being picked up more because we are following up on a regular basis, or is it actual higher incidence that we see?
Thank you. The association between these two disorders which commonly occur is definitely there. There are odd studies which have shown no association, but by and large, thyroid dysfunction is about 2 times more common in type 2 diabetics compared to the non-diabetic people. The Western data says that the incidence can be anywhere between 64% to about 10% or so. And subclinical hypothyroidism obviously is more common. If you take care of people who have diagnosed cases, then obviously that is excluded. But if you prospectively look at, you find that you have more subclinical hypothyroidism. After you announced this meeting, I looked at the data published from our own country. There was data published by Professor Dilip Kumar et al. From Nellore. They had 500 consecutive type 2 diabetic patients. And they found that subclinical hypothyroidism and clinical hypothyroidism was there in 19.6% of the people. The Western data about prevalence is about, in non-diabetic population, about 4 to 5%, so twice as much is reasonably okay. In our country, we say that 10 to 11% people have got hypothyroidism of various kinds. So 19.6 is almost twice as much. Now, the associations in the past have been with aging, of course, with the female sex and positivity of antibodies. And in this study also they found that the association was more with age in female sex, and they also found that metformin use also influenced the incidence of hypothyroidism. People who were using metformin had a lower incidence compared to the non-metformin users.
Right. Maybe that's a very important issue that you raised. Maybe we can take that forward even now about metformin, and there are studies that suggest that metformin leads to lowering of TSH. Whether it's good or bad is of course another issue. So when you say that those who are metformin users had lower incidence of hypothyroidism, whether that's because falsely they are not picked up because the TSH is suppressed, or is it doing something good for the thyroid? So can we have maybe can we have Dr. Shailesh Lodha to tell us about it? Please unmute yourself.
Yeah.
Yeah.
In recent years, there have been some publications with this showing this kind of data, but these are small studies, and what they have finally concluded is that metformin is able to reduce the TSH in people with subclinical hypothyroidism or in overt hypothyroidism, but in euthyroid individuals, it doesn't alter the TSH. And there is one study, one Indian study also by Dr. Rajesh Rajput, recently done, and there he has shown that although again the number of patients again was only 30, and they have shown that in antibody negative patients again the TSH might reduce, but in people with normal TSH, with TPO positivity, there was no effect on TSH. So these are some anecdotal studies, but again, there are contradictory studies also where they have shown that it doesn't alter at all in whether it is antibody positive or negative or subclinical or overt. So, but we can conclude that there, if at all, there is a minor effect on TSH. It may be just a borderline lowering of TSH in people with mildly elevated TSH.
Right. Yeah. I mean, there are studies that I can recall where they have given a TSH cutoff. I mean, if TSH is above, let's say 2.5 or
2.5, yes.
Or 2.5, okay,
Yeah.
right.
Yeah.
Then metformin may lower the TSH, but if it's below that, it doesn't affect. So
Yeah.
can we have maybe the wisdom of Professor S.V. Madhu as to whether metformin is good or bad for the thyroid? What should we take away from all these studies that Shailesh has kindly gone through and told us about?
Thank you. I think it's very simple that at least metformin is not bad, largely speaking. If anything, it is good, not only in terms of the TSH, but also there are other studies which also say that probably it affects other aspects of structural and anatomical changes also favorably, and prevents the formation of long-term cancers and others in thyroid. So overall, I think, speaking overall, metformin may be beneficial, if anything, not.
But if right, yeah, but if we say that it does reduce TSH level, then can it not give rise to central hypothyroidism?
No, I think if I heard Shailesh correctly, it doesn't reduce it beyond a certain level. It's only when the TSH is elevated, it brings it back or brings it down to normal, or it doesn't. The elevation is reduced, so to speak. And that too, in some studies, it's only an antibody positive. So it's an evolving area. So at the moment, I think it's too much to conclude that it actually harms, and it falsely may show things, but especially it may alter TSH a little bit here and there, but beyond that, I don't think it would be a major effect or major problem.
Right. So the message that can go is metformin can still be freely used without being greatly concerned about its effect on the thyroid. Would all the panel? Yes, Sushil. Yeah,
Yes, sir.
Professor Gupta.
Madhu has really pointed out a nice thing, but there are studies to show that if you got hyperinsulinemia, you have got large goiters, more chances of thyroid cancers actually. The people who are on metformin, they got smaller amount of thyroid size actually, and they got less incidence of thyroid cancers in these people.
So that's exactly what Professor Madhu said.
Yeah. So and this is through probably mTOR pathway and through IGF-1. The exact mechanism is not known, but it's highly speculative. So metformin, beyond suppressing TSH, has got much more effects on thyroid. And as Dr. Madhu said, it's a really evolving area. Still, we more need to understand whether metformin can be used in euthyroid goiter or not, or whatsoever it is still not very clear actually.
Great.
So there is one Iranian study which I came across,
yeah,
and it has shown that metformin users can have lowering of size of the thyroid as well as lowering of the nodule size also if they have a nodule.
Yeah.
But again,
right.
These are very minor observations.
Yeah, right. So we go back to Professor Gupta because we already have a question in the chat box, and before we go to that question, maybe Professor Bipin Sethi told us that you have higher prevalence of thyroid dysfunction in those even with type 2 diabetes. Now, what about looking at it the other way around? So if you have a patient with hypothyroidism, does he or she have a higher chance of getting diabetes?
You're asking me, Dr. Prabhakar?
Yes.
If you look at hypothyroidism, it can lead to the glucose intolerance actually. If you look at GTT in hypothyroid subjects, they have an impaired glucose tolerance. That's very old studies which have shown us. But having hypothyroidism, chance of diabetes, I'm not very sure that, but in general, hypothyroidism can cause impaired glucose tolerance, but not exactly diabetes, until it's type 1 diabetes associated with it.
Right. I mean, if you look at studies, there would be studies, of course, for everything possibly under this earth, which have suggested that baseline TSH, the higher it is, the higher the chance of developing diabetes. And there are studies which suggest that hypothyroidism may increase the chances by not a great amount, but maybe by 15-20%. And so actually the question we have in the chat box is how frequently do we need to screen for diabetes in patients with hypothyroidism? From what Professor Sushil Gupta has suggested, possibly there is no special or higher or special need for screening for diabetes. Is that correct, or should we do it more diligently?
As a routine protocol, we should screen, but specifically having a hypothyroidism, whether we should go for on a proactive basis for diabetes, I'm not very sure. Other panelists can elaborate on that.
Would anyone else like to weigh in?
I think in general also for a country like ours, people are recommending opportunistic screening for diabetes in any case. And when somebody comes with hypothyroidism, that itself is a good opportunity. And even if there are indirect suggestions of glucose intolerance, it might be worth screening patients who come for hypothyroidism like any other illness to the hospital. But I don't think any specific recommendation that only hypothyroid patients need to be screened for diabetes is of any good
right.
has any sound basis.
Right, because we promised to Dr. Bipin Sethi that we'll try and let him off early. So let's come back to him. So while on the issue of hypothyroidism and glucose homeostasis, I mean, what is the effect of hypothyroidism on glucose control?
Well, as Sushil said, elevated fasting plasma glucose has been demonstrated in most type, most patients with hypothyroidism. If someone is hypothyroid, there are issues about appetite, about decreased glucose absorption, insulin resistance, and decreased insulin clearance by the kidney. So if a diabetic patient is on insulin, the insulin clearance is reduced and the chances of hypoglycemia are more. So insulin treated patients specifically are at risk for hypoglycemia. Dr. Shubhankar, you know that whenever a patient with type 2 diabetes mellitus comes to the emergency with hypoglycemia, we are supposed to screen for renal dysfunction, hypothyroidism, adrenal insufficiency, etc., etc. So decrease in the requirements are there, and whenever somebody is treated for hypothyroidism, again, there might be an increase in the insulin requirement. So hypothyroidism per se is a state of insulin resistance, has differential effect on the insulin secretion. Insulin secretion also reduced. The net result is increased fasting plasma glucose. But in a patient who is on insulin treatment, the insulin requirements would go down, and treatment of hypothyroidism would then result again in a diabetic patient receiving insulin in increasing the insulin requirements.
Right. So while we say that hypothyroidism itself is associated with increased insulin resistance, we also say that those who are insulin treated, if they are hypothyroid, then the risks of hypoglycemia are more. So can we have a little bit more on how thyroid hormone affects glucose homeostasis? Maybe Professor Madhu, if you could highlight for our August audience.
Yeah, actually the interactions of thyroid hormone and glucose homeostasis are quite complicated and involves several mechanisms. The most important, I think, in general, thyroid hormone increases the hepatic glucose output, and this has several mechanisms. For example, through gene expression of GLUT2, hepatic GLUT2, or gene that is increase in gluconeogenesis, increase in glycogenolysis. All of these actually increase the hepatic glucose output in general. Therefore, in hyperthyroid states, you will expect more of hyperglycemia, and maybe to some extent the reverse could be occurring in a hypothyroid situation. The insulin itself, as I think somebody did point out, there is changes in insulin clearance, even endogenous insulin clearance. The half-life of insulin exogenously given also changed. It can reduce in the presence of thyroxine, and therefore in thyrotoxic states it naturally decreases. And in hypothyroid states, it could be the other way around. The insulin degradation therefore is decreased. And also suggested that in the presence of thyroxine, there is more secretion of proinsulin rather than the insulin itself, and that also leads to less effective insulin being produced. So this is another effect that can change the glucose homeostasis.
Is that excess thyroxine you meant, or normal levels of thyroxine?
It's the effect of thyroxine. So in excess thyroxine state, this would happen naturally. Right. Naturally, more the thyroxine in the blood, this would manifest more and more. But the effect of thyroxine is such that it will cause this effect. So that's the basis. Basis of this is the thyroxine having an effect in producing biologically inactive insulin or proinsulin. Then it could also have effects on growth hormone, catecholamines indirectly, as we all know, glucagon. All of these could also affect glucose metabolism. Then in the periphery, in the skeletal muscles, for example, it actually increases the glucose disposal into the skeletal muscles by altering the GLUT4 mechanisms. So that's another effect which can alter the glucose metabolism. In the adipose tissue, it increases lipolysis, and this indirectly increases insulin resistance because there is free fatty acid levels in the blood increase, and then they can also increase the insulin resistance. And lastly, but not the least, as a direct effect, absorption of glucose from the gut in the presence of thyroxine increases, and therefore in thyrotoxic states, it will tend to increase glucose absorption. In hypothyroid states, it decrease the absorption. All these effects will directly affect glucose metabolism one way or the other. And of course, there are several indirect effects. The indirect effects can be through adipocytokines. Again, an evolving area, as I said, it's not very clear, but adiponectin, leptin, and even ghrelin, for example, have been shown to be different in thyrotoxic and hypothyroid states, but then it's not, the studies are not settled yet, and there are both directional changes have been observed, and we need to wait to understand the actual effect on adipocytokines. So there are a whole lot of ways by which thyroid hormone itself and the resultant hypo or hyperthyroid state can alter glucose metabolism. By and large, hyperthyroidism causes progression of, let's say, prediabetes to diabetes versus glucose metabolic control in a diabetic state, and by itself can cause hyperglycemia. And in a hypothyroid state, already has been explained, especially in insulin users, there's more hypoglycemia. That's a broad effect of all these mechanisms.
Right. So we do have sort of differential effects on different organs on thyroid of thyroid hormones, which can affect glycemic status. And to take us further, let's hear from Dr. Chitra, who hasn't yet spoken. Maybe we haven't allowed her to speak yet. So, Chitra, in what way could the diagnosis of diabetes be affected in someone who's got hypothyroidism?
Right. Thank you for that question, sir. So the most maybe frequently used screening tool, at least in the urban setting for diabetes, happens to be HbA1c. And in thyroid status, especially hypothyroidism, the effects on HbA1c seem to be a little more pronounced and maybe different than the effects that are seen on blood glucose levels. So one of our colleagues, Dr. Rana Bhattacharya, as part of his DM thesis, did this very important study in which he took two cohorts of people. One was individuals, all of them are individuals who didn't have diabetes, one with overt hypothyroidism and the other group with overt hyperthyroidism, and did baseline HbA1cs in both the groups and then rechecked their HbA1cs following treatment. And what was interesting to note was, while there was no change in HbA1c levels in the hyperthyroidism group, the group who had overt hypothyroidism to start with had a baseline HbA1c which was higher. And after treatment, the HbA1c dropped, which was significant, without any change in the blood glucose levels. So that is a key finding which was found, and this finding has been reiterated in many other studies. Another paper which came out from Manipal, Karnataka, tried to refine this answer a little bit more and found out that amongst people who have hypothyroidism, who also seem to have coexisting anemia, are more likely to have greater changes in HbA1c than in people whose hemoglobin levels are normal. We all know that thyroid status hypothyroidism specifically does affect anemia. So if there's coexisting anemia, we might need to be more wary about interpreting that HbA1c value. Whereas maybe if there is no anemia, we might be more confident that with treatment, the HbA1c might not drop as much.
So will that be related to maybe hypoproliferative anemia and hypothyroidism, meaning lower turnover of the RBCs, and therefore greater exposure of the RBCs to whatever the ambient glycemia, and so more chances of HbA1c being higher? So the etiology of anemia and hypothyroidism can be varied. One of them could be the alteration in the production itself, but although in Dr. Rana's study there was no change in the reticulocyte count that was noted, so that's probably not the only way in which the HbA1c values can be affected by hypothyroidism itself. Right. And finally, for the practicing physician, what is the extent of this effect? Can it make a diagnosis, change the diagnosis, a normal individual being diagnosed as diabetes because of this? How big is this change? So the delta can be anywhere between 0.3 to 0.6 percentage of HbA1c. That's what's been noticed. So if you're looking at the range of pre-diabetes, yes, it could misclassify individuals as having type 2 diabetes if you've not taken overt hypothyroidism into account, and similarly misclassify people who have normal blood glucose levels into pre-diabetes. So that's something to watch out for. Right. So that's something in overt hypothyroidism. Maybe when we look at the HbA1c, maybe we need to make sure that the A1Cs are not borderline where it may have been an effect of the hypothyroidism itself. So if we go back to our chat box, and we didn't have Dr. Mehrotra speak yet, so maybe Dr. Mehrotra, if you could take this question from Dr. Nilanjan Mukherjee. We have actually alluded to this, and maybe we have confused our audience a little bit. So the question is, if the patient is in hypothyroid state, metformin reduces TSH, but with medication, the patient coming down to euthyroid state, metformin doesn't affect the TSH level. So maybe we re-look at this issue, Dr. Mehrotra.
I think the panel has discussed very clearly if the TSH is elevated, then you may have an effect of metformin on the TSH. But the TSH is already normal, then we don't see the effect of the TSH going down with metformin. The question about the correlation between impaired glucose tolerance or pre-diabetes and effect of metformin on the TSH, I think we will not going to see a clinical difference between a TSH of say, which was say around say 3 or 2.5 going down to less than 0.1. That will not be seen. The only question may be in the case of TSH is say around 4 or 5. That may not be really evident on metformin. In case somebody is really having a goiter or you have a suspicion that the patient may be hypothyroid, then you may need to follow up the patient much more religiously or more closely to look for overt hypothyroidism.
Right. Okay. And while we have you, maybe you could also tell us if someone has got subclinical hypothyroidism, which is fairly common and detected whatever way, and has got diabetes, does he or she have a greater chance of progression to overt hypothyroidism?
Yeah,
would diabetes increase this risk?
Definitely. I think the literature again is a little bit controversial here. But the overall, if you look at the literature, they do suggest that a patient who has got diabetes and has elevated subclinical hypothyroidism, there are more chances of the disease progressing to overt hypothyroidism. It's more commonly seen in patients who are antibody positive and who have got elderly females. They've got a more chance of progressing to the disease. On the other hand, we have other school of thought who say the risk is quite less. In case your general population, like the people antibodies are negative, the risk is less than 1% in 5 years. But if you're antibody positive, the risk is 5% in 1 year. So again, it basically comes down to the status, what is the reason of subclinical hypothyroidism? If somebody is recovering from illness and you have a mild elevation of TSH, that disease may not progress. He may go back to normal, like in a normal population. But in case the autoimmune background is there, has a family history or a female or antibody is positive, that patient is likely to progress to overt hypothyroidism.
Right. So let's come back to Dr. Shailesh Lodha. Having a patient who's got both type 2 diabetes and hypothyroidism is a fairly common occurrence, just because because both diseases are common. So if someone has got hypothyroidism, does it add further risks to the microvascular complications of diabetes? Please unmute yourself.
Yes, again, there are some studies which have been done in subclinical hypothyroidism and diabetes. If these two conditions are coexisting together, then they say that probably untreated subclinical hypothyroidism might pose a small risk in progression of diabetic nephropathy. And again, there is no risk on diabetic retinopathy. But the reverse, in subclinic, if diabetic patients, they have subclinical hypothyroidism, and if you leave it untreated, then that might worsen the diabetic retinopathy. So both these complications, they might become worse if subclinical hypothyroidism is not treated. But again, I came across a totally contradictory study where they showed that it is neutral. That means whether you treat or not treat subclinical hypothyroidism, it doesn't make any difference.
So I come back to Dr. Bipin Sethi. please, if you're still around.
I'm around.
Yeah, thank you. So this is now a difficult area. So when we decide on whether to treat subclinical hypothyroidism, maybe you take TSH as one of your guidelines. If it's above 10, you treat. Below 10, you may or may not treat. So then shall we add diabetes as another indication? If someone has got subclinical hypothyroidism and also has got diabetes, then we should be treating subclinical hypothyroidism, because then you will be reducing the risk of progression of retinopathy and nephropathy.
I think the evidence is just building up in that area, and it cannot lead to a strong recommendation yet. So if you look at the recommendations by the various societies, they have not as yet said that subclinical hypothyroidism should be treated in the setting of diabetes. Of course, there are softer indications somebody has got, and for this audience, of course, it is relevant that infertility, people planning for pregnancy, positivity of antibodies remain strong indications. In the arena of cardiovascular disease, dyslipidemia, diastolic hypertension, smoker, these are all small indications, subtle indications. So there could be ground in sort of working on this further and then trying to see whether there is a role and whether it is preventive or it's just an association, because the association between type 2 diabetes mellitus and diabetes itself is not based on very firm principles of this causes that, therefore that happens, like happens in type 1 diabetes. So I think this is work in progress, and till we have firmly established that retinopathy or nephropathy, or for that matter cardiovascular disease, are more prevalent in subclinical hypothyroid who are diabetic, I don't think there can be a strong recommendation for treatment for this. I'm aware that this work is there, and then some people have said that it might actually also worsen the cardiovascular disease, but there are studies which show that it doesn't. And some people say this could be because of the renal dysfunction that is there. This could be because of insulin resistance that happens. But I think it's too early to sort of add another indication for treating this otherwise tenuous entity, because the meta-analysis for treating subclinical hypothyroidism is skewed by numbers about 10 and age between say 45 to 65. Below that and above that, there doesn't seem to be an indication. There's a nice little curve which says that the influence of treating subclinical hypothyroidism is best in the middle-aged people, more so if they've got antibodies. So I think it is, these are early days, and I don't think that we should recommend this. Otherwise, what will happen is that if different cutoffs, subclinical hypothyroidism as such is looming large and wanting an indication for treatment. There was an article in the BMJ which said that the risks of osteoporosis and rhythm abnormalities are going to exponentially increase if we would treat these people, because many times we would overcorrect them. So I wouldn't personally feel that neither should we. I think it's overstepping somebody else's question that there are no recommendations for screening. There are subtle indications to screen. So if you find something, I think we can just follow them up as other cases of subclinical hypothyroidism and treat them if there is indication. Otherwise, diabetes in and by itself, as of now, I would be, of course, begging to differ with this. We would not, at least I would not treat, but opinion of other people like Madhu, Ravi, Sushil is most welcome in this regard. And I stand to learn then.
Right. Yeah, I would sort of echo what you said, and especially for subclinical hypothyroidism, I find it difficult to find a pathogenetic mechanism. Maybe with overt hypothyroidism, I do understand about at least renal function with decreased renal blood flow and all that. But with subclinical, I find it difficult. But of course, I'll welcome opinion from all the other faculty members. Maybe starting with Madhu.
I think there is no point in differing with what Bipin Sethi so eloquently put. So I do not think we should recommend treating subclinical hypothyroidism on the basis of current evidence.
Right. Yeah. And Sushil?
Yeah, I agree with all the panelists actually. I would not be treating it unless you have a very specific reason. You're a goiter, you're a T2 antibody positive. The standard guidelines to treat subclinical hypothyroidism as in a non-diabetic subjects, I would not differ from those guidelines.
Right. And Chitra, would you like to wade into this, which is becoming a little bit confusing area? So about complications of diabetes and thyroid dysfunction. We heard about microvascular complications. There are some papers which suggest there may be higher prevalence, as Dr. Lodha told us. What about cardiovascular disease and thyroid dysfunction in someone with diabetes?
We do understand that both conditions, whether it be hypothyroidism or hyperthyroidism, do have effects on the cardiovascular system. So maybe we can start with hyperthyroidism. We do know that rhythm abnormalities are extremely common, and heart failure is more prone in individuals who have hyperthyroidism. So that is definitely something that we'll have to, it's clear cut there. We need to identify it, look out for it, and optimize it. I think it gets a little murkier when we come to hypothyroidism, maybe specifically subclinical hypothyroidism, which is probably more prevalent than overt hypothyroidism. So overt hypothyroidism by itself, we do know has effects on diastolic blood pressure, and there's also evidence to suggest that untreated overt hypothyroidism in the long run can lead to changes in the endothelial function, also lead to increased carotid intima thickness, all of which are surrogates for cardiovascular disease. So if you're taking individuals who have just overt hypothyroidism, because if you're specifically trying to understand, does hypothyroidism at the end of, let's say, 30 years of life increase cardiovascular disease, I think there is evidence to suggest that people who have TSH in the higher range, specifically more than 10, do have increased cardiovascular events and increased cardiovascular mortality. In the range lesser than 10, there seems to be a rising incidence of cardiovascular events as TSH rises. But the corollary of that is, if you start treating all of them, will you be conferring benefit to all of the people whose TSH might be less than 10, is a question which is very difficult to answer. And the presence of diabetes does add such a huge variable there that understanding that difference in the context of coexisting hypothyroidism, diabetes, and cardiovascular disease is very difficult to figure for ourselves at all. But at least in individuals that is, say, who have overt hypothyroidism, we would want to bring TSH down to normal. I think treatment of subclinical hypothyroidism to bring down incidence of cardiovascular disease is again a tricky question, because the variables there are many more. Coexisting obesity can increase your TSH, presence of dyslipidemia, presence of hypertension, all of those are variables which make it a very difficult situation to answer the direct effect of the two. I hope I've not confused the audience.
No,
more than
so the clear message, of course, if you have got overt hypothyroidism, you treat anyway. In subclinical hypothyroidism, just presence of diabetes does not alter your decision yet for treatment. Yes. You go by the standard criteria. That's what I've heard. I've learned, right?
Absolutely so.
Right, great. There's a question in the chat box, maybe Dr. Mehrotra. Dr. Shivani from Bhopal, and Bhopal had that gas leak, so they are much more alert to pollution. So are there any role of environmental factors in thyroid disorders as diabetes risk increases with environmental pollution? So once again, even in type 2 diabetes, for type 1, we know autoimmunity is at the background. For type 2, if we find a higher prevalence of thyroid disorder in diabetes, is there an underlying pollutant driving both? Do we have some answers?
Very difficult to answer. I don't think we have any environmental kind of long-term study to follow up to say that these environmental pollutants will be the cause for the hypothyroidism in these kind of group patients. There are some hypotheses, but I don't think we have any hardcore evidence to suggest that if the link will be like what we see in puberty, or like we see in diabetes, or we see in Graves. We have the same kind of relationship with subclinical hypothyroidism.
Yeah, so at this point of time, we are not sure of definite environmental factors. Is that what you say?
Yeah.
For for hypothyroidism. Yeah. And any other opinions from other faculty members?
May I add, sir?
Yes.
Over the last few decades, there have been tremendous increase in new occurrence of overt and subclinical hypothyroidism. And one school of thought, of course, there is no substantiated, no substantial data, but there is a thought which is coming up that probably environmental pollutants, particularly the thiocyanates in various industries, they might be adding to the growing occurrence of hypothyroidism or even subclinical hypothyroidism. Because many people ask why hypothyroidism is discovered so frequently. Either it is because of over-testing or something else like environmental pollution. So we don't know.
Yeah, maybe at this point of time, we don't have a definite answer. That could be a reason, a speculation at this point of time. Yeah, Madhu, are we correct?
I think so. I don't think there's any direct relationship that has been established in evidence at all to suggest that.
Right. So now we come to the other part, use of anti-diabetic agents. Now, we talked a whole lot about metformin. What about the other anti-diabetic agents? Do they affect thyroid function tests? Should we be wary about it? So would Professor Sushil Gupta take us through this?
We have discussed metformin, but in general, sulfonylureas and thiazolidinones and insulins do not generally affect the thyroid function test actually. There had been a lot of studies early 1960s and 70s that showed that it could, but current generation sulfonylureas, they don't affect. Thiazolidinones, they do not affect the thyroid function test.
Thiazolidinones may have some, not directly thyroid function test, but in the context of maybe thyroid associated ophthalmopathy.
Yeah, that's a different issue. But the thyroid function test, it does not affect actually.
Yeah, so where should we be wary about using thiazolidinones in management of diabetes? Should we not use if someone has got Graves' orbitopathy?
I'm sorry, I don't know the answer to this question actually.
Yeah.
Over to you.
Yeah, would anyone like to comment?
Graves' orbitopathy, of course, there are studies to suggest that, thiazolidinones can actually increase the predisposition or increase the progress. And I think one should use this drug with caution if the patient has Graves' orbitopathy.
Yes, possibly. What about, Sushil, what about GLP-1? Should we still say those with a family history of men with a history of medullary carcinoma should not use a GLP-1 analog?
Animal studies have shown that there could be increases in medullary thyroid carcinoma, but it is the caution comes from those studies actually. And therefore, it is not generally if you have got a high calcitonin or a family history of medullary carcinoma or you have got a medullary carcinoma. So they should not be used in that kind of scenarios.
Yeah, I mean that's a standard label would say so. That brings us, of course, to legal issues. But at the same time, we also do say that human C cells do not express GLP-1 receptors, whereas I think rat C cells show. But I don't know whether in any case, of course, this is a rare situation where most of our physician colleagues possibly will not be dealing with these individuals. So it may be referred to Professor Sushil Gupta to take the final decision.
I would not be using GLP-1 receptor because that's a legal binding actually. So as an absolute contradiction to do that. So I would not even think of trying it actually on an experimental basis based on that.
Okay, right. So yes, Chitra.
So in the clinical trials which have looked at the use of GLP-1 receptor analogs in individuals who don't have a history of medullary thyroid cancer, in human beings as well, they do see a rise in the calcitonin levels after the administration of the molecule. Maybe not an increased incidence of medullary cancer itself. So that I think is also something why they are worried about not using it.
Right. So that's why we rely so much on the prudence of Professor Sushil Gupta. So we don't use it. Right. And then let's go on to a broader issue. And can we, Bipin, I think we should excuse Bipin. He has to go back home without a driver. So he should be allowed an early departure from this program. Thank you very much, Bipin. If you're still around, I can't see right now. Thank you very much. So we will see you in future programs, I'm sure. So the issue of thyroid disorder in diabetes, we have an idea that they are seen more often than by chance. And so what should be the screening strategy for thyroid disorder, first of all in type 1 diabetes and then in type 2 diabetes? Maybe can we have Dr. Mehrotra, and then we can ask the other panelists also.
I think we have a consensus on the screening in type 1 and the pregnant ladies present going for pregnancy. There's a lot of consensus on that. The moment we have a type 1 diabetes patient diagnosed, we do look for a TSH and a T2 antibodies and follow up based on that. ADA makes a very specific recommendation that you do test on diagnosis, but do again repeat the test when that A1C is controlled or the patient is better control. Otherwise, overall, the recommendation is to check at diagnosis. If the antibodies are positive and TSH is normal, we do check after 6 months and then at 6 monthly interval. In case the antibodies may not be so highly positive or the goiter is not there, then an yearly checkup should be sufficient. Any lady of diabetes going for planning a pregnancy should have a TSH done and a T2 antibody levels done, and we have different guidelines to follow based on that. The literature is a little bit more controversial regarding the type 2 diabetes and the screening for thyroid disorders. If you look at the benefit of screening, as we already discussed, the patients who are having a high TSH with diabetes may have a more progression of macrovascular complication, may have more progression of dysglycemias, may have more progression of the cardiovascular disease. That is the point which says we should be screening and more chances of converting from subclinical to overt. The other benefits of screening in patient of type 2 diabetes for the subclinical hypertension. Other way, the other authors we say that the risk is progression is antibody negative is less than 1%, and majority of the patient of subclinical hypertension may not progress further. So that area is quite controversial. If you look at the various guidelines that we have, the ATA says very clearly at 35 you should screen, and then every 5 years you should screen. ADA says you screen at diagnosis, or in case patient has dyslipidemia, or patient above the age of 50 years. Or you should palpate the gland of every patient of type 2 diabetes. If they have a gland enlargement, then we should check it. ACE practically has a similar guidelines. You test for at diagnosis, palpate the gland, and then based on those risk factors, you can decide when to screen further. They don't give you a very particular kind of time frame that we should be doing it every year or every 2 years, every 3 years. The UP, the US Prevention Task Force, they don't give any recommendation. They say these patients should not be screened on an annual basis or a yearly basis. British Thyroid Association, again, does not give you a kind of different guideline, but do say that based on the clinical risk factor or the palpable normality, you may decide to screen. So we have kind of some societies saying we should at least agree on diagnosis, we should be checking it, or check if they have got a serious dyslipidemias, or they have palpable abnormalities, or antibodies positive. These are the group we should be screening on a regular basis. But in case patient is young, has no family history, has no goiter, and the baseline TSH is normal, we need not screen them on a timely basis.
Right, so there are so many different guidelines. I think you've sort of summarized and given a very pragmatic view as to what to do. Can we ask Dr. Madhu as to what he does?
Yeah, I also believe that what Dr. Mehrotra has said is perfect, and I do not think we should go ahead and just the presence of diabetes should result in annual or a biannual or 3 yearly checks as a routine. It should be dependent and consequent to other factors being present, which might like dyslipidemia Gautri mentioned. Maybe a diagnosis, one might still say we could do a thyroid function test, and we often do it in our clinics as well, but not at regular intervals thereafter, unless indicated in specific cases.
Right. Thank you. So let's go back to the chat box before we wind up. We have Dr. Gaurav Jain from Lucknow, who asks, do patients with positive anti-TPO antibodies have a higher chance of developing LADA? Anyone would like to take this question? So those with type 1, yes.
They don't develop LADA, but in case somebody, a diabetes patient has antibody positive, and clinically we're thinking in terms of maybe autoimmune disorder because he's lean, has no family history, there we suspect more. But all the patients with diabetes with antibody positive, if you suspect LADA, I don't think that we have that kind of evidence in front of us.
Right. So this was going the other way. So those with type 1 diabetes, you screen for autoimmune thyroid disorder. Those with autoimmune thyroid disorder, because of much lower prevalence of this autoimmune pancreatic disease, we do not routinely screen for that. Right. And also, does weight gain in hypothyroidism as a factor in insulin resistance play a role in beta cell degeneration? So would Professor Sushil Gupta like to take this question?
Can you repeat the question?
It's there in your chat box as well. So Dr. Jain, does weight gain in hypothyroidism possibly also increase insulin resistance? As it is, you said in hypothyroidism itself, there is insulin resistance. And then if there is weight gain, could that play a role in leading to beta cell dysfunction further?
Obesity can lead to it, but hypothyroidism is going to worsen, aggravate that further. I really don't think so. And
right.
So I would say no. Largely I would say no.
Right. Yeah. So and finally, maybe Dr. Shailesh Lodha, which thyroid disorder, hyper or hypo, is more prevalent in association with diabetes patient?
Yeah. We all know that hypothyroidism, the prevalence is about 10 times more than hyperthyroidism, and it is again represented in the same way in diabetic population also, but because the two conditions are so common that we see more hypothyroidism, as we have discussed previously.
Right. We have left one question, maybe partly because the moderator myself could not understand much, but everyone else is invited to look at it. Dr. P.G. Sunil Kumar from Thiruvananthapuram, T3, T4 within normal range, TPA positive, thyroid peroxidase antibody positive with low TSH, no significant variation with neomarcazole after an initial improvement clinically, and T4. I didn't understand.
So he's trying to say that the patients who had subclinical thyrotoxicosis, there was no improvement in the TSH, which is of course normal after we don't know what is the duration. So right. if I can understand the question the way I understood is, people who have got subclinical thyrotoxicosis or even clinical thyrotoxicosis, the improvement in the TSH occurs much later. Because of the lag effect that happens from the pituitary, you can have a normalization of T4, the TSH remains suppressed. Very rarely, individuals who got positive TRAB antibodies. These TRAB antibodies can interact with the tenocytes and the thyroid trophs, producing suppression of TSH without thyrotoxicosis also. So that situation, you can expect TSH to be low despite the patient being euthyroid. So if I've understood your question properly, because the name is as long as the city you belong to, it's possibly that you need to wait for longer period of time, and then the person's TSH would normalize. Sometimes it takes 3 months, sometimes it takes 6 months. But clinically, this patient had subclinical thyrotoxicosis, and the reason why that patient was treated probably might have been to look after the cardiovascular disease, or if the woman was postmenopausal, look after the bones. So I think primary reason is you have to establish that the patient had Graves' disease and a subclinical thyrotoxicosis, which definitely required treatment, TSH being less than 0.01 by ultrasensitive assays. And if all those things are fulfilled, then we can still wait. The TSH will normalize. You don't have to worry.
Thank you, Bipin, for saving the day for us. Thank you.
You know, I wanted to learn everything, so I thought, okay, why not stay for another half an hour?
Yeah, that's great. Thank you. And if the organizers allow, maybe we'll take the last two questions that are there in the chat box, to not directly addressing diabetes and thyroid dysfunction, but very common question. Maybe Chitra, can you take it? The first one, that is a lady of 56 having hypothyroidism, taking thyroxine 100 microgram daily. TSH is 1. When should one titrate the dose? She's been taking it for the last 5 years, and Dr. Deepak Kumar wants you to answer. Do we need titration? How often we need to do a test? These are the things I'm sure that is in his mind. Chitra, we are following up primary hypothyroidism, let us say.
Sorry, I lost my audio in the middle.
Right. Okay. So we have a question from Dr. Deepak Kumar, which talks about a specific instance of a lady of 56 of primary hypothyroidism on thyroxine. So just tell our audience as to when should we, maybe after starting treatment, when should we next check, and then how often should we monitor in the long run?
All right. Thank you for the question, sir. So ideally, it takes about 4 to 8 weeks, maybe 6 to 8 weeks for the TSH to normalize after we initiate the levothyroxine dose, which we calculate based on the ideal body weight. So it would help to just wait and then recheck TSH at that instance. And then once your TSH is within normal range, maybe we could do the second evaluation maybe between 3 to 6 months. And if both of those values are normal, it is recommended that we only recheck TSH annually in the patient who's on a stable dose of levothyroxine.
I suppose that's fairly standard, and all our panelists will agree on that. And that is more possibly, it's not that from year to year the dosage will change. Quite often the dosage does not change. It's essentially to make sure that someone is on a regular dosage and all that. So we have a question from Dr. Ashok Agarwal from Chandigarh. And I think we don't have many people representing the eastern part of the country. So the question is, how common is celiac disease in the setting of autoimmune thyroid disease or type 1 diabetes? So maybe I'll have to represent the East, or can we have maybe Dr. Madhu and Dr. Sushil Gupta answer how common is celiac disease in type 1 diabetes, let us say?
It's around 4 to 6%, I believe, type 1 diabetes and celiac disease. Similar figure exists for hypothyroidism, around 4%.
Mm-hmm. Then, Madhu?
Yeah, more or less the figures are same. Some studies do suggest a slightly higher percentage. Some people even say 10%. But yes, I would say it is common, or even there are studies suggesting even 15%. But largely around that figure.
Yeah, and I must say that at least from our center, we find a much lower prevalence. Very few, if any, actually, when you do at least a TTG antibody, very low positivity rate. Yes, Bipin?
Well, traditionally, South does not seem to have much of celiac disease, but there are instances when we pick up this in people whose TSH is not normalizing despite adequate treatment in hypothyroidism. And one of our colleagues from Bangalore suggests that gluten-free diet can be given to anybody whose TSH is inexplicably high. But I think the incidence is lesser here, maybe 2% or so, but we have not done it in a systematic fashion that is required. Maybe Ravi can comment, is more systematic and
Yeah, gluten sensitivity is being proposed for kind of a lot of disorders in the population. You see a lot of patients coming to on gluten-free diet just to avoid obesity or just to avoid thyroid problem. But we agree with Bipin, the incidence is not that much that we should be really worried about that fact. But it's commonly to see in type 1 diabetes around 4 to 5%. But in thyroid disorders, it's quite less.
Yeah, so gluten-free diet is not for anyone.
Not for everybody. Not for everybody.
Right.
In general, we are not getting so much of celiac disease in hypothyroidism actually, despite extensive investigations. So the report literature is Wheatman reported around 3 to 4%. We are not finding so far.
Yeah, and I must also mention in those instances where TSH is not coming down persistently high despite apparently adequate doses of thyroxine, I usually look for it. I have not yet been rewarded by a positive test result yet in this situation. And this will be the absolute final question. We won't drag any further. This is a Saturday evening, I do understand. So the question is, when TSH or T4 levels of both are borderline reading with clinical features suggestive, should one start treatment? Dr. Yash Paul from Amritsar. And who better to answer than, I mean, we could have anyone from the panel. Can we have Dr. Shailesh Lodha? We haven't seen his face for a little while now.
Can you repeat the questions?
So patient has clinical suggestion of whether hyper, whatever, but the biochemical findings are borderline. Let's say hypothyroid. Maybe mildly elevated TSH, T4 is normal, but there are some suggestive symptoms. So should we treat?
Yeah, I think Dr. Madhu elucidated this point that if antibody is positive, if there is obesity, if there is dyslipidemia, pregnancy, growth failure, these are some of the indications where we treat subclinical hypothyroidism. Otherwise, we can repeat the test after 3 or 6 months and then see what is the progress there.
Right. And even if we treat, I mean, my general principle would be to repeat the test anyway and to see the patient anyway and see whether those symptoms for which we started treatment actually got better with our treatment. If they had not improved, then there is an opportunity to also discontinue treatment. Would others agree or disagree on this? Madhu?
Because when we say subclinical, there should be no symptoms. So if somebody has symptoms, it is suggested that you might, as a soft indication, treat, and if the person improves in those symptoms, whether it's obesity, hair loss, dryness of skin, or whatever, then you continue. Otherwise, you tell the person that the symptoms with which you started the treatment are still persisting, and there is no need for continuing treatment. There is no basis either.
Right. Madhu, were you saying something?
I was saying the same thing, that it's a fair enough call to look at the symptoms, and if they don't respond, then you stop it.
Fine. So I think we had a wonderful evening learning from all our experts from across the country. We did understand that thyroid disorders possibly are somewhat more common in those with diabetes, but there is no specific recommendation, strong recommendation that every person with diabetes should be monitored for thyroid dysfunction at definite interval. It has to be individualized based on symptom, signs, etc. And we also did understand that there may be some effect of the medications that we use to treat diabetes, oral especially, and of those, metformin being the commonest agent, there can be some effect on thyroid functions and maybe some decrease in TSH levels. So we need to keep aware of that. And finally, that if patients with hypothyroidism and someone who's also got diabetes, if he or she is being replaced with thyroxine, we may expect slight increase in the requirement for the dosage of anti-diabetic medications. And similarly, on the other side, if hyperthyroid individual is being treated successfully for the hyperthyroidism state, and as that individual is made to come to euthyroid state, maybe the anti-diabetic medication doses may need to be adjusted. So we need to follow these up them more carefully. So with these few words, I would like to profusely thank all our panelists and all our those who joined this Saturday evening. And I have got some figures with me, which should, I mean, all of you could actually next time, I mean, where elections are in UP, so you could all maybe try and be a candidate, because you are also very popular. There has been a registration. There have been at least more than 1,000 individuals, 1,000 doctors who have tuned in to listen to you, to learn from you, and hopefully together we can improve our practice and what we give to our patients. Thank you, all of you. And it's back to Intas, Mr. Amit Arora.
Thank you, Professor Shubhankar. I think we started practice pulse in endocrinology in June 2020, as soon as the COVID struck us. And I think, although the entire world is disturbed because of COVID, but I would say this is some positive of COVID, that sitting in the comforts of our home, we can do, such quality education, and the people across the country can learn from the galaxy of experts who have joined in today. I think if we have to do this program physically, then it would have taken a humongous effort to get all these experts together, and there would have been a lot of logistic challenges which we would have faced. But today, we have people from different parts of the country, and I would like to profusely thank all of you for accepting this unique invitation for this unique program, wherein there are no didactic lectures, and the brain behind this program, as you all know, is Professor Shubhankar Chaudhary. He suggested that we should change over the program, and we should do it in a form of a talk show, wherein there can be freewheeling discussion, and the questions can be answered. And I must say thank you to him for giving this opportunity and continuously guiding us to do these programs. And we are very motivated to continue to do these programs, the continuous medical education for the physicians across the country. I would like to thank our expert panel today, Professor S.V. Madhu, for kindly accepting the proposal for being here tonight. Professor Sushil Gupta, he has been there on Practice Pulse in Endocrinology and coming back over again for this program. Dr. Bipin Sethi, again, who you have been there with us many times in past. Dr. Sailesh Roda has come over for the first time, and I'm sure you would have enjoyed the interaction and teaching the people across the country. Dr. Ravi Mehrotra has been with us on various platforms, and Dr. Chitra, of course, has been there with us in past as well. So thank you, all of you, for joining in today and clarifying many doubts which the physicians across the country would have. And I would like to thank the delegates who have joined in from different parts of the country. As Professor Shubhankar mentioned, we had more than 1,000 delegates who logged in today, and I'm sure they would have become more wiser in treating their patients in the times to come. So thank you very much once again from Intas, and my name is Amit Arora, and I work as a Vice President for this division Zenith, which makes anti-diabetic drugs like Dabawal and Teglip. So we request, if you find opportunity to prescribe, please do prescribe in your patients. So thank you very much once again, and good night to all of you. from here
Okay,
at
sir.
INTAS. Thank you and
Thank you. Good night.
Namaste everyone.
Thank you.
Thank you. Goodbye.
All.